Welcome. I'm Dr. Lata McGinn, President of the World Confederation of Cognitive and Behavioral Therapies. It is my pleasure to welcome colleagues and students from across our member organizations around the world to today's webinar. The World Confederation of Cognitive and Behavioral Therapies, or the WCCBT, is a global nonprofit organization whose mission is to advance the global dissemination and implementation of evidence-based cognitive and behavioral therapies. We work alongside our 8 continental member organizations across the world to promote training standards, expand access to care in underserved regions, and partner with organizations such as the World Health Organization to ensure that effective psychological interventions reach people everywhere, not just in high-resource settings. It is in this spirit that we're delighted to host today's webinar. We are honored to have with us Dr. Ken Carswell, who leads work on scalable psychological interventions at the World Health Organization. Dr. Carswell has been central to the development and global dissemination of the WHO's Psychological Interventions Manual, a set of practical, flexible, evidence-based, low-intensity interventions rooted in CBT principles that have been rigorously tested in multiple cultural contexts and are designed to increase access to effective mental health care worldwide by both mental health specialists and trained non-specialists. In addition, he has been instrumental in developing and promoting global guidelines on how these evidence-based psychological interventions can be implemented effectively across diverse contexts. Today, he will be presenting the WHO's Psychological Implementation Manual, which complements the interventions manuals on which he presented to us last year. If you missed that webinar, please do go to our website at WCCBT.org to access the recording of his webinar on psychological interventions. While the Psychological Intervention Manual describes what to deliver, programs like Problem Management Plus, Step by Step, Thinking Healthy, or Self-Help Plus, the implementation manual focuses on how to deliver them. It provides a structured roadmap for policymakers, program managers, and mental health leaders to plan, adapt, and scale evidence-based psychological interventions within their health systems. For practitioners and students, understanding the principles of this manual is essential because successful implementation ensures that the interventions we value reach the people who need them. This framework is especially critical in closing the treatment gap and promoting equitable access to psychological care worldwide. Please feel free to submit questions in the chat for Dr. Ken Carswell. He will answer them following his presentation. Dr. Carswell, welcome.
Great, thank you. And thank you very much for the kind introduction. And also to WCCBT for inviting me for this webinar today. So I'm just going to share my screen, and then we'll make a start with the webinar. Okay, just a second. There we go. Okay, so hopefully you can all see my screen now. Is that right? Okay, good. So thank you. And as Dr. McGinn was saying, yeah, my name is Dr. Ken Carswell. I work at the Department of Non-Communicable Diseases and Mental Health at WHO. I'm based at headquarters in Geneva. I'm a mental health specialist, a clinical psychologist from the UK by background. I've been at WHO now for about 10 years. And I started off there working on one of our interventions called Self-Help Plus, and then over time have taken over work on the portfolio of psychological interventions, digital and innovation, because one feature of many of the psychological interventions is an aspect of innovation. So today I'm going to be presenting primarily on the Psychological Interventions Intervention Manual, Implementation Manual. But I'll also give a little bit of a background and go through it quite quickly about some of the other interventions, and also really give you some ideas of how these interventions are now being scaled. And I also want to talk a little bit about service delivery models and really the types of conditions that we need in order to ensure that implementing such interventions is successful and also safe. So we're going to share all of this information, I believe, in an email afterwards. But I also wanted to mention that very recently, a couple of weeks ago, we released our Foundational Helping Skills Training Manual. And I think this will also be of interest for the audience today. This manual, which I won't be covering in any detail, is a manual that is based around a sort of competency-based approach to training in foundational helping skills. It uses some of the features from our Equip project and Equip platform, and provides us competency-based training on 15 of the foundational helping skills that are needed really for all helping interactions. So we see it as something that is relevant, not only for professionals, but for non-specialists. We think it's going to be particularly useful in what we call pre-service training environments. So, sort of clinical psychology trainings or counseling trainings and similar. So you can find this by just doing a Google search for Foundational Helping Skills W.H.O. And you can also see the recent webinar we did on it by searching for Foundational Helping Skills YouTube W.H.O. and you should be able to find the information there. Now, everything I'm going to talk about today, you can find on our main webpage, which is our Psychological Interventions webpage, which you can see here. And again, you can search for Psychological Interventions W.H.O. For more information on that. And all of the work that we do at W.H.O. and everything that we produce is open access. And as I go through the talk today, hopefully you'll see some of the benefits of these open access interventions and what it means in terms of supporting scale and support to many people. So just a brief introduction to the context. I think probably, as we all know, we have a large mental health treatment gap around the world. I think no matter what we do, however many people we train, we're never going to have enough professionals, therapists, counselors, psychologists, or highly trained individuals really to meet the needs of many people. Now, one part of the solution to this is what we call task shifting, having trained and supervised non-specialists who provide the type of support a therapist or counsellor would provide. Now, we've known for many years that over the last 20 years that we have a growing evidence base on this area of work. There's been multiple research trials in many different contexts. This includes cultural context, as well as countries of low, middle, and high income setting countries. And we also know that psychological interventions can be effectively delivered by non-specialists when they're appropriately trained and supervised. And we find that these approaches generally use fewer resources. Now, sometimes we call these scalable or low intensity interventions, and we're seeing that they're very effective, particularly for severe emotional problems such as depression. And we've also seen them now scaled again in countries of all income levels. Now, when it comes to the types of interventions that can be delivered by non-specialists and by the psychological interventions that can be delivered, we have a set of recommendations in WHO. These can be found both in the MHGAP guideline recommendations, and they're also outlined in the Psychological Interventions Implementation Manual as well. And just briefly to mention, the types of interventions we're talking about today are really ones that, when we say scalable, they have sort of some specific features. Often they focus on some form of innovative delivery, perhaps a reliance on things like IT support, self-help guides, a reliance on lay people or non-specialists. Usually there is one treatment perhaps for multiple problems, something we call transdiagnostic. Often they do not require any form of diagnostic assessment. They may require fewer sessions, and there's often a focus on self-management. And if we compare this to more specialist delivered interventions as specialists, as CBT practitioners, psychologists, We may see that there might be different manualized approaches, or it might take more training. It could require more sessions, and we generally expect people to be more, I guess, competent in a wider range of skills. And I'd say my own probably reflection on this work on scalable psychological interventions is really that what we've attempted to do at WHO and what these interventions really aim to do is almost try and distill the most effective components of different interventions and also the ones that might be most translatable across settings, across cultures. So, for example, there's often quite a focus on things such as stress management through breathing, behavioral activation, problem management. They're some of the often some of the main sort of features, things that we could sort of see that might translate across different settings and are also fairly easy to learn. And perhaps we could compare that to some of the more sort of cognitive skills, which may not work so well in some settings, or may take a little bit more training. So that's been, I think, my own personal reflection around this. Now, when we're talking about these interventions, really we see many places that these can be implemented. Now, this diagram that you can see here, you can see it in much more detail in our World Mental Health Report. And really this maps out the different places or the different aspects of a comprehensive mental health system. And we would see psychological interventions being feasible for implementation in many of these places, both in terms of sort of community mental health services, but also, and also within primary care, but also in places beyond the health sector. So, thinking about social services, thinking about delivery in school, prisons, workplaces, and similar. So with the right type of training, with the right type of workforce, we think that these can be delivered in many places. And really, again, just a couple of reflections here, around scalable interventions. I think in my experience, as we've been working on this area, some of the common concerns that we often hear from people when we introduce these interventions is that because they're shorter or more scalable, they might be of lower quality. There's often a concern that there might be a loss of professional identity or a loss of importance for professionals. Often there's sometimes people find it hard to believe that these simple methods can actually work. And there's also often a belief that they're only for mild problems. But really our experience now, in many years now of using these different interventions, is that they're of high quality, that actually it maybe boosts the importance of specialists or professionals because they're then more important for things like supervision, support, training. The more scalable approaches, they may not work for everybody, but they can work for quite a large proportion. So we reserve the more specialist skills for people who need it. And they can also help with people with more severe problems. I think the really important part is about the supervision and support of the non-specialists, and I think that's an important thing to just reiterate. Now, in terms of our work at WHO, as we were sort of saying in the introduction, we've really been wanting to set the conditions to bring these interventions to scale. So we have developed a range of different psychological interventions. We have ones that are based on CBT. Many of the ones here you can see, like Problem Management Plus, EASE, which is an intervention for adolescents. We have Self-Help Plus, which is based on acceptance and commitment therapy. And we also released a manual, interpersonal therapy manual in collaboration with Columbia University so that we could provide access to a group IPT approach. So we're sort of trying to cover and release manuals as open access that cover a range of different evidence-based interventions that have been shown to be suitably delivered by non-specialists in different settings. And I should mention that all the manuals that we've released at WHO are based on high-quality randomized controlled trials. Now, I won't go into this slide in detail, but this just gives you a sort of sense of the types of trials that we do. It's a selection of the trials. It's not a complete list, and the types of settings. The majority of the trials that we do, and before we release a manual, we tend to do 2 trials, and we want pooled positive results between the 2 trials before we release it. And we keep ourselves to that standard, really, to ensure that we've got a better chance and we're more confident that it will work across multiple places. And as you can see from the list here, we're talking about trials with populations that are substantially affected by adversity, either through by being refugees, being on the move, or coming from a conflict affected area. And again, this map just shows a selection of our trials and the types of locations where they were conducted. So we've spent this time, many years. This work started, I think, in around 2012, before I arrived at WHO, and it's continued up till now. And we're continuing now with still developing interventions. We're working on another one called STARS, which is a CBT-based chatbot, a non-AI chatbot. We've completed 1 RCT on that, and we're about to go into a second RCT. And the aim of it really has been to develop a range of interventions that go across resource intensity. So if we look at this map here, we can see at the bottom left, we have something called Doing What Matters in Times of Stress, which is a self-help book. It's been translated into over about 30 languages now. It's been used in different ways. It can be provided both unguided or as guided self-help. Then we come on to other guided self-help interventions like Self-Help Plus, and the cartoon image here you can see is something called Step by Step. Then we have our group and telephone delivered interventions. These are things like Problem Management Plus, which is a CBT intervention, or a group IPT, and Thinking Healthy, which is another CBT intervention. And then at the higher end here is really the sort of specialist delivered interventions. Now, it's important to sort of think about this resource intensity when we are actually planning and implementing different interventions. And I'll be coming back to that now as we move into the section more on the intervention manual. So really, we developed this manual because while we had developed the different manuals for facilitators, so the different intervention manuals, we've also developed the training manuals to go alongside many of these. There were often questions and there were often concerns about how do you actually set these interventions up. So we wanted to write something that was accessible to both program managers, to specialists, to psychologists, to CBT therapists who might be wanting to use and set up a service that uses these non-specialist delivered interventions. And so we came up with this manual, the Psychological Interventions Implementation Manual. It has 5 very distinct sections and then a set of annexes that really take you through the whole process. And what I'm going to do now is just very briefly run through, in brief, each of the sections with some key examples where relevant. So the first thing I'll sort of say, and this is you probably can't see it very well because it's probably quite small on your screen, but I think this has turned out to be an incredibly helpful checklist. So in one of the annexes, we have a checklist really for implementing psychological interventions. So before anyone starts, this is really something that someone can run through very quickly to sort of get a rough idea, a rough understanding of what might be involved. Because obviously to set these interventions up, we know that they can work very well in trials, and we've seen that. But obviously, trials and research trials are often very well funded, they're very well planned and similar. And when we move into implementation, obviously, there are different aspects that you need to consider. There are different things that need to be completed. There are different aspects that need to be set up. And the whole manual covers all of this, but this checklist is a very helpful way to just, think, is the service, is this area, is it ready to develop something or deliver something? What might be some of the funding requirements? What might be some of the training requirements, and so on. So the first section, really in planning. So the whole manual, I'm just going to go through the key messages here, but each of these key messages is really laid out in detail for each of the sections. So here, when we're planning, one of the first aspects is about establishing the purpose of introducing a psychological intervention based on a situation analysis, understanding the needs, understanding the culture, understanding why you want to do it. This really is a community and multi-stakeholder endeavor where we really need to include community representatives, people with lived experience of mental health conditions, people within the health service or within the implementation team, because obviously this will help us get a better understanding of what's needed and will likely have more success. Then it's about selecting the evidence-based intervention. Also then about mapping out the different available services, health services, rehabilitation, education, protection, and so on. And really building those referral links and the links between both for referral in and for onward referral. Because obviously without those, we can't give a full support to individuals. We also want to be thinking here at this time of models that might maximize delivery efficiency. And I'll come on to this a little bit later in another section of the presentation. We'll also want to identify the types of workers that will deliver the interventions, the types of formats, and also really specify how and where these will be delivered. So there's a lot of thinking that goes into this part because each intervention and each setting will be very different from the next, and the requirements of different populations will obviously vary. So for example, if a population has wide access to mobile phones, then doing some form of digital self-help might be quite feasible, especially if they're distributed across a wide geographical area. However, and then something like, for example, our self-help book or self-help app, Doing What Matters in Times of Stress or Step by Step, might be suitable there. If people are more located in smaller communities, then something like Self-Help Plus, which is a big group for up to 30 people, might be more suited and more fitting there. So just to give you, a sense of that, these are some of the interventions I'm sort of talking about here. So this is really where this resource piece, this idea of what interventions are available, how can they be used, how can they be adapted, all of this thinking is an incredibly important part of setting up the services. And I should mention, obviously, I'm mentioning here WHO interventions, but there are obviously many other evidence-based psychological interventions that are available. So after this planning, after having a good sense of who your workforce are, what you're going to be doing, the model you're going to be developing, then the next really important part is about adaptation. Now, this is really key. So what we know about delivering psychological interventions and the evidence is that they can work across different cultures and different languages. But we know that adaptation increases the effectiveness and makes it much more likely they'll be successful. So in the adaptation process, we outline a whole process that we follow at WHO, and this involves, and the approach can be varied depending on the needs of the area and the needs of the setting. But, it might involve a situational analysis to understand the idioms of distress. So how do people communicate about their distress? It might involve understanding the types of mental health difficulties that are around and similar, which would have been done in the planning stage. Then we're looking really at some form of like language translation. So it might be getting a team together to run through and do an initial translation of the language. And then a process that we call cognitive interviewing, which is when you might take the intervention or the translation to the community and really ask key questions to ensure that it's understandable, it's not offensive, and it's also relevant. So there's sort of three key criteria that we think need to be covered under this adaptation phase. Now, this, depending on the setting, can be shorter or longer, depending on what the needs are, depending on what resources are available. But what's very important about it is about documenting the adaptations in a very systematic way. And I'll just show you something in just a second about that. But another thing about the adaptation process is that it's not just about the language. You know, it is also about adapting the actual content. Now, what we say in the manual is that you want to stay as close as possible to the original manual and to the original content. But that means you can still change some of the exercises. So for example, in Problem Management Plus, we use a form of stress management breathing, which is, you know, breathing into your belly and breathing in for a count of 3, breathing out. But in a setting where maybe there's already an existing cultural mindfulness practice or a Buddhist practice or similar, then that aspect can be sort of switched in for a different type of exercise. So when we think about adapting the content, we're thinking about keeping the content true to its original form, but also still using the actual format that's used and more similar for the community or the area where the intervention is being used. And this form here, which is in the manual, this just gives you an idea of how you can sort of systematically document these aspects. So it says here on the left, the stage of adaptation. So we have, you know, was it at the literature review or qualitative assessment? Was it during translation? Was it through the review of stakeholders, through the evaluation during provider training, or through the pilot testing? And then you can also then identify the justification for changing the original content. So for example, it wasn't accurate, it wasn't understandable, it wasn't acceptable, it wasn't relevant. So this gives the adaptation team and everybody using the intervention a good idea of what's being changed and why. Now, once we've adapted the intervention, and I should mention adaptation is not a one-off exercise. You're very likely to sort of do an initial adaptation. Then when you're doing your training, you might then do sort of further adaptation. So it's more of an iterative process. Once you've done your adaptation, we then move on to more about how we prepare and sustain a competent workforce to deliver the psychological interventions. And in this chapter, in this aspect, we talk about how you might select providers. And we suggest selecting based on attitudes, personal characteristics, knowledge, skills, and experience. So people don't need to have the skills already. We train for the skills, but really we want people who have the right sort of attitude towards life and right attitude towards helping people. Then there will be, in terms of the preparing the workforce, some form of training in the intervention. There'll be expectations around attending supervision. So it'll be very important here to not only have in place your helpers, but also your trainers and your supervisors. And absolutely critical to the success of interventions is supportive supervision, so that providers, people delivering the interventions can continue to learn and also have a safe space to really further learn, further develop their skills, but also go to someone more experienced when they come across difficult cases, perhaps people who are at imminent risk of suicide or similar. In this chapter, we also talk about the regular use of both fidelity assessments, competency assessments, also monitoring attendance throughout the training and also throughout the delivery of care so that we can ensure quality. So as you can probably see by now, the manual very much takes you through in a step-by-step manual or a step-by-step way, all the different aspects that need to be in place to deliver interventions safely. Now, you may have already come across EQUIP. So EQUIP is a WHO and UNICEF platform, which was developed really to help improve the quality of psychological, psychosocial, and mental health support and helping skills. It's really aimed at trainers, supervisors, and program managers. And it uses uses a range of competency assessment tools to help both measure competence in the skills, identify any potential harmful behaviors, and really help people to progress and develop. And it does this through a questionnaire or a competency assessment tool which lists out the different behaviors that you might be looking for as a trainer. It's something that we've tested in a range of settings. It's very much evidence informed, and it's a really useful tool for helping to prepare your workforce. And then we come on to the next section, which is about identification, assessment, and really delivery. And in this section, we talk a lot about how we might identify people who might benefit from psychological interventions. So, for example, will screening be used? Will some form of sort of community referral be used? Will it be through identification in the primary healthcare clinic? Will it be through social care services and similar? But there needs to be thinking about how people will be identified, how they'll be assessed, and how they'll be tracked throughout the whole of the process of receiving the psychological intervention. Now, obviously, absolutely key to this is ensure is some form of good assessment. This might use different screening measures. But in addition to the screening measures and the measures such as PHQ-9, GAD-7, the WHO WHODAS, as well as these sorts of measures, there also need to be protocols in place for ensuring that people who are at imminent risk of harm, whether that be through self-harm, violence against children, gender-based violence, there need to be both protocols in place to both identify this, manage, refer on, and provide additional support. And also under this section of identification, assessment, and delivery, we also talk about the importance of follow-up care for people who drop out or who do not complete the intervention. So really what we're sort of saying here is that as well as providing the intervention, there are these other aspects that really need to be taken into account. And sometimes these are some of the hardest parts to sort of set up. They take a lot of planning at the beginning to try and set up appropriate referral systems, ensure that those things are in place, and really not only does putting these things in place ensure success, it also ensures safety. So I just want to very briefly just touch on here just one model when we talk about both in the planning stage, but also when we're talking about how we might deliver interventions. Just want to briefly mention here, the importance of thinking about the different models that we might use, and also the importance of screening here. So I'm sure many of you are very familiar with the ideas of stepped care. So this is where we might chain together both less resource intensive interventions with more resource intensive interventions. And in this type of model, we really have some sort of pre-screening. So this is the initial screening to identify if someone is suitable for a psychological intervention. Depending on what that screening says, you can then go straight to the first step, which might be offering some form of self-help. Or if you have more resources, you might set up your system that people with more complex presentations go straight to someone with more experience. In the model I'm showing here, you might have the first step of offering self-help. If that person then doesn't respond to that, you then rescreen them after completing that first set of interventions. And then if they still need help, they go up to the second step. So with WHO interventions, this might be offering some form of self-help, followed by a more in-person delivered intervention like Problem Management Plus. Now, I mean, this model has been delivered in many places around the world, but we now have, there's a range of trials completed in Europe used by the Respond project, which used 2 WHO interventions. So in this setup, the people who came into the trial and scored above cutoff on, for example, the PHQ-9, so they scored above cutoff for depression. The first intervention they received was an app version of our book, Doing What Matters in Times of Stress. They also got that with a 15-minute telephone call once a week from a trained helper. And people who continued to have a distress above cutoff then received Problem Management Plus after this. Now, there's 4 research trials on this, one with healthcare workers in Spain, one with labour migrants in the Netherlands, one with refugees and migrants in Italy, and the final RCT was with homeless migrants in France. Out of the three of the trials, there's the fourth one still, the results are still coming in, but out of the three trials, they've all shown positive effects and significantly positive effects, quite similar to the one you can see here. So what we saw in Spain with healthcare workers was that this brief stepped care model worked well. We also saw that around 75% of people stepped up after the first self-help intervention. So, you know, in many ways, that's quite a high number. So we need to think, well, there's obviously people need more than just sort of self-help. But it also shows us that if we're careful in our thinking about how we might design our services and how we might identify and treat people, we can also hopefully help around 25% of people with just that first self-help step. So it then gives us a lot more capability of helping that much larger populations. And these are some of the sort of models that are discussed within this manual. We also talk about the model of collaborative care. And there's a lot of, I guess, rich information in there around the types of things that people can put in place that might be helpful and that might increase the coverage of these different interventions. Now, the final chapter is really about monitoring and evaluation. And this is thinking more about how we might use a range of output, outcome, and goal indicators to monitor and evaluate the effectiveness, acceptability of what we're setting up. Now, obviously, this is not a standalone thing. If we're using screening measures and similar for the different within our interventions, then obviously that can form part of our monitoring and evaluation. We might also be thinking about sort of qualitative interviews, looking at actual numbers of people who attend, looking to see if there's any dropouts, any areas of high dropouts, and really using that information both for reporting, maybe to funders and donors, but also really to help us improve our services. So we talk a lot in this chapter about the different ways that you can do this, about how you can involve all stakeholders, and we also give a list of the different types of what we call means of verification, so that the ways that you can actually understand and use this information to improve your service. And I mean, again, one of the things we talk about in the manual is how you can use one measure for multiple different things. So you can both use the pre and post screening measures, both to support the people receiving the help, because you'll understand better who needs help and who doesn't. But you'll also be able to use that to calculate maybe the overall effectiveness of the intervention itself. But it can also be used to sort of show just, you know, the severity of the types of people who are coming to the service. So there's many ways that these measures can be used. And written in the manual, we talk about how it's, you know, important to sort of try and bring these things together. So we're trying to use the same data for maybe multiple means. And again, within the manual, we have a range of different example measures that can be used for screening and assessment. And we also refer on to other means of verification that can be used. So really, that's a quick tour through the psychological interventions implementation manual. And hopefully, as you can see, it really lays out, it's really a cookbook, the recipe book for how you can sort of set up these sorts of services using non-specialists in a range of different settings. And we've tried to make it as practical and helpful as possible with that. So now I just want to spend really a few minutes of sort of, you know, showing what we can really achieve. And I think this has changed. This is some of the data I'm going to be presenting now, is some of the stuff that's we've learned about in the last sort of few months. So I just want to touch on briefly just a couple of examples of you know, what we mean by this, by implementation, and how we can sort of get scale, and how these interventions are now really being used. So our first one, Self-Help Plus, which is a group-based stress management intervention It's audio, it's based on acceptance and commitment therapy, and it was designed really for conflict-affected populations where access might be difficult. We're now really seeing this being scaled widely in Ukraine. There's been over 100 NGOs that are now delivering it. There's been over, I think it's 400 what they call resilience centers. So these are centers that are present in most areas of Ukraine that provide mental health support. There's been around, I think, 400 people or facilitators in the resilience centers trained who have now reached around over 8,000 people. And again, this is a great example of what can be achieved when we plan things when we plan things in a way and we use the right ways of training and support, and we ensure that they're cascaded down carefully, and we ensure that people are trained and supervised. So we're sort of seeing this as a great example of how interventions can be scaled. The other one I just want to mention briefly, we're also seeing Problem Management Plus, which was one of the first interventions that we developed. It's transdiagnostic, it's based more on CBT. We have a group version and an individual version. This is now being scaled now more and more widely. It's being used in high-income countries, low, middle-income countries. It's being used with Venezuelan refugees and migrants in Colombia. It's being used in New York at the moment in a project there to help scale up access to mental health services. And Project Spirit in Switzerland, it's being delivered now throughout Switzerland, where I'm based, both to refugees, but increasingly in other populations. So, for example, it's now being delivered, there's plans to be delivering it within prison populations. So we're really sort of seeing these interventions, and I think this is part of the beauty of them being released as open access. We're really sort of seeing them being used in very creative ways and creative places. And the last really example I want to sort of give of this is our step-by-step intervention, which is a guided self-help intervention for depression. It's delivered through a self-help app. This was developed over many years in partnership with the National Mental Health Programme of the Ministry of Health in Lebanon and a number of other stakeholders. We started in 2016 with developing a website and an uncontrolled pilot that ran through several rounds of cultural adaptation. We had a definitive RCT, and it's now being implemented as a service in Lebanon. The manuals from this, we're now in the process of publishing. So I'm hoping by the end of this year, we'll have the step-by-step content out again under open access, and also our self-help manuals. So the manual that describes how you can deliver guided self-help along with the W.H.O interventions, but also with other interventions. Just like the other WHO interventions I've mentioned, this is backed by randomized controlled trials, which were conducted in Lebanon. But what we're really seeing with this, and this is one of the main things I wanted to mention, is again, we're sort of seeing this wide-scale countrywide adoption and adaptation. So it's being used in Lebanon. Thailand, the Ministry of Public Health in Thailand have also recently taken step-by-step and doing what matters in times of stress and set it up as part of their national digital mental health platform. It's in early stages. They've had, I think, a couple of thousand people so far, but they're expecting a very big response to it. There's been very good feedback to it so far. But all of these have been successful, I think, because they've taken this very methodological approach to planning and to implementation. They've involved communities, they've identified the needs, and really that's, I think, been part of the recipe for success. And as we can see here, step-by-step has also been adapted for India. And I think this is a lovely example of what I was saying about adaptation and planning and why these things are important. So within India and the Indian version of step-by-step that's being piloted there, they took the original program of step-by-step, but they completely changed it by not using illustrated pictures because they didn't really resonate with people. Instead, they turned it into a series of brief videos, also ran it through WhatsApp because that's where people could actually access the intervention in a far more effective way. and it's being piloted at the minute, but there seems to be sort of very good engagement. So really, I was sort of showing these examples just to really sort of highlight what we can achieve when we really think about this process of implementation, when we really go through these different aspects and go through the different processes that are needed to really sort of set up the psychological interventions. So yeah, thank you. I'll pause there, and that leaves us hopefully some time for questions. Thank you.
Thank you, Dr. Carswell. I guess I'll start with some questions that we've received.
Sure.
So one is from Dr. Chris Nezu, who is actually one of the co-developers of problem management therapy. She's asked a question, which is a charity that she has called fullofpossibilities.org. And she's developed scalable interventions based on problem-solving therapy it's meeting with success in Kenya. That was what it was developed for. And so she uses animated, culturally relevant sort of animated videos on a free YouTube channel. And has been very helpful in sort of reaching both students and lay mentors. And she was curious about your thoughts about the use of animation.
Sure. I could talk about this for a long time because I've got lots of thoughts about this. Not so much about animation itself, but more about how we approach interventions and developing interventions to get more scale. Now, I've been really keen for a long time to try and take our Doing What Matters in Times of Stress book and animate that and put it for free on YouTube, because I think that's the way that you can actually really reach hundreds of thousands, millions of people, perhaps. With the animations, a lot of our feedback when we've used animations or drawings, illustrations, a lot of things. I don't think you can please everybody. Like, so often you get sort of reactions where some people think, well, these are too childish, or, these don't quite speak to me. And I think often you're sort of trying to get something that is good enough for many people. I don't think you'll ever sort of get sort of perfection for it. But one of the things we've found in our own work when it comes to animations and illustrated self-help interventions is the importance of iterative design and the importance of human-centered design. So really working with communities to understand how do the animations work best, what type of animation is wanted, what draws the person in, what really communicates the messages that you're trying to communicate. And I think that more creative side, when you're using animations, there needs to be a bit more time spent on ensuring that you sort of get them right. But I think they can be hugely helpful, and I mean, it'd be interesting to see if you do that, to then obviously monitor. I don't know if there's any way that these things can be monitored through a research design, but it'll be a fascinating thing to try and research and understand, because I think animations are a way of reaching a lot of people. Yeah.
Thank you, Ken. Another question from one of our attendees, Charlie Davidson, is he says, my training as a psychologist and most of the evidence base aware of assumes that the client is reasonably safe, housed, etc., and their behavioral cognitive response to the world, self, or others is disproportionate to the actual threat. However, in community work, and I presume WHO's implementation science, I'm often in the role of trying to help someone respond effectively to unreasonable circumstances that are ongoing. Do you have recommendations to help therapists know how to use therapy techniques for people after having exhausted options to support housing, safety, or other basic needs?
So I think if I understand the sort of question correctly, I mean, I think it's often an assumption of ours as psychologists or therapists that people do need to be in relative safety, and I think there's obviously a lot of truth to that. In our sort of trials and in our experience, I think a lot of the populations that we're working with are very much affected by adversity. So they're in very, very challenging situations. But I guess what we need to do is ensure that they are still safe. I think a lot of this comes through some form of referral on. But I think what I'm reading here is that maybe people don't have access to sort of these things. So there will always be limits. I think, we will always, I think psychological interventions can help people in very, very difficult situations, but they're not going to solve a whole problem. But in terms of actual suggestions or thoughts, I mean, if you look on our website, the Doing What Matters in Times of Stress book, we've found that an effective intervention, and it's related intervention Self-Help Plus. We've seen that effective with communities in very difficult situations, in refugee settlements, refugees from South Sudan living in northern Uganda. And while these interventions are not going to solve everything, and still all of those different aspects are needed, what they might give people is just either a little bit of relief or a little bit of energy to be able to try and access some of those other aspects. So I think I'll probably say we would see this as, one part of the solution, but obviously it wouldn't ever be a full solution. And those other aspects of needs that you're mentioning are also hugely important. Yeah.
Thanks, Ken. I know that this question you will address with the manuals that are developed for children and adolescents. The question is, have you adapted any materials for children and adolescents with learning disability, intellectual disability, or autism? And do you find that you need to address some of the stigma related to mental health that still exists in communities in which you're working? So
Yeah, no, absolutely. Yeah. So when it comes to people with learning or young people, children, adolescents with learning disabilities, one of the interventions we have is something called caregiver skills training. So you can look that up. You can find that also on our website. I didn't really mention it here, but that's one of the interventions that we have. We also have an intervention called EASE, Early Adolescent Skills for Emotions. They haven't been specifically adapted for people with any form of sort of intellectual disability or autism or learning disability. But the caregiver skills training is very much sort of directed towards that. In terms of the second part of the question about stigma, absolutely, this is hugely important, and it's something that we cover in the manual because in terms of the identification and support and how we get people into the services, stigma is one of the issues that we need to address the most. One of the reasons why we're sort of seeing quite a bit of success from self-help interventions as well is because it means that people can access these without necessarily going to a health centre, without identifying. They can do it in their own time. And it's one way for some populations for people working around the stigma. But this is hugely important.
All right. Another question is, what is the future of the relationship between non-specialists and generative AI chatbots? How much of a role do you think will AI take on in the future with delivering psychological interventions? So I'm sure you have a crystal ball there, Ken. But
A huge topic, and obviously a very relevant one right now. Obviously, I don't know. I think at WHO, it's something we are increasingly aware of. Obviously, all of us have to prioritize. We all have limited time, but it's something that falls under my area, digital, that we're becoming more and more aware of and interested in, and thinking about how do we respond. On a personal level, I think there are both benefits and risks. I mean, I think already there's probably many people using generative AI chatbots for support. There's obviously been recently some very concerning reports around both risks and what they might be doing to people, and how they might be, not giving good advice, or even not keeping safeguarding sort of issues to mind. But I think they're gonna probably take a role. I guess that the important thing will be, how do we shepherd it in such a way that we ensure that it's safe and effective? And I mean, one thing I'd really love to see people starting to do research on is, Gen AI chatbots, in terms of the multi-purpose chatbots that we can all access ourselves. what are they like? Are they effective? Do they help? Like just even sort of doing research on that type of chatbot as opposed to a beautifully designed therapist chatbot that's been designed by a psychologist, because I really feel that it's going to be those types of chatbots that people are going to be using, even if we develop amazingly great therapist chatbot type programs. So I guess we'll see. The thing is, this whole area is changing so quickly, and it's difficult to know what will happen, and it's also difficult to know what will happen in terms of regulation and how governments might respond to it. So I guess we will see how it develops. But I think there's a lot of potential as well as many concerns.
Right. And you're testing it now, right? Well, that's one of the trials you mentioned.
No. The trial we're doing, we started off in 2017 developing an intervention for adolescents, and we took a human-centered design approach, which meant that we worked with adolescents to co-design it. And the design we came up with was a chatbot, but this was way before AI was there. So our chatbot is a rule-based chatbot, but it's working very well. But we designed it in such a way that it works, it still works. So you feel like you're sort of still talking to somebody. And the benefit of it, I'll probably feel very old with it about 6 months from now, but one of the benefits of it is you can obviously control it a lot more, because people get exposed to 10 sessions of training, as it were, in different techniques, and they will all get the same sort of training. So, but there might be a way that can be used by other people to sort of somehow integrate it into a Gen AI, a chatbot or similar. So, but it's yeah.
Well, thanks for the
We
clarification.
haven't quite gone there yet.
Yeah. I guess I mean, I know you probably have faced many barriers and you have had to overcome them, but is there any one that you sort of stands out as something that you really had to overcome? And obviously it's maybe built into the implementation manual and how to overcome it, but what would you say are the most common barriers you have seen in countries when trying to implement these interventions? And
Question. All right, a few. I think one of the first ones is the community identification. So there's sometimes a feeling of like, build it and people will come. But that isn't necessarily our experience, not just with psychological interventions, but with mental health in general, that there has to be some form of community education there, community engagement, identifying people, overcoming stigma, communicating to people that this is a real problem that they're experiencing and that there is help and support for it. So that's one barrier. I think that's a big one. The stigma is a very big barrier, and trying ways to overcome that. And there are many ways to overcome that, and there's a lot of good advice on the WHO website. I think the other one, and this isn't maybe a barrier, but a hugely important piece, is this idea of thinking about what best suits the context, and also the use of screening tools and assessment tools. So the idea of, if we assess somebody, are they mildly, moderately, severely depressed? Sort of putting in those assessment measures, both pre and post, and maybe after another intervention, so that we can track people through the journey and we can ensure that people get their needs met and get what they need. So I think that is something I'd like to see more of, I guess, is that being a really central part of our thinking, along with the thinking of, well, what best suits this community and what best suits my resources. If I don't have the resources to deliver something like Problem Management Plus, which is 5 sessions face-to-face, rather than trying to deliver that and not having the resources for it, well, instead I could deliver a self-help book with a guided self-help call of 15 minutes per week. So it's that sort of creative thinking, co-creation with the community that I think is really powerful and would be is important. Yeah.
well, thank you so much, Dr. Carswell, for such a clear and inspiring presentation. You've shown us not only the importance of evidence-based psychological interventions, but also how the WHO has developed this elaborate psychological implementation manual that provides that roadmap to actually make them a reality. I think for us as mental health professionals, supervisors, trainers, and students, it's critical for us to understand that how important that implementation piece is. and how important it is to assess that competency. I know Dr. Carswell mentioned the EQUIP program. We actually did have Dr. James Underhill from the WHO who described the EQUIP program. That is also on our website. So on behalf of the WCCBT, I want to thank Dr. Carswell once again and thank all of you for joining us from across the globe. We hope today's session has sparked new ideas about how you can integrate implementation thinking into your own professional and academic work. We look forward to continuing this dialogue with you and working together towards our shared goal, ensuring that effective psychological care is accessible to all who need it, no matter where they live. Thank you.
Yeah, thank you, Dr. McGinn, and thank you everybody for attending. I couldn't agree more that it's an important reason for having these webinars, and thank you for the opportunity. Thank you.
Got it. And if there are any other questions, I will take them and I will pose them to you after the fact.
Sounds good.
Thank
Great. Thank you very much.